Just a little summary of what we do at Heartland. I've been with Heartland for 11 years. I spent 9 years active duty Air Force prior to moving back to Minnesota. I grew up in suburban Minneapolis, but we're pretty excited to be able to provide fairly bumper-to-bumper orthopedic care involving joint replacement, sports medicine. I have a subspecialty certification in sports medicine, which just means that I do a lot of stuff through the fiber optic scope. And I took a big extra multiple choice test in about 2008 to let me say that. We have physical therapy with our clinic. Craig is here from Glacial Ridge, who we partner with doing physical therapy for people from this area. So a couple years ago, we see people from about 186 different zip codes. And once upon a time, Heartland Orthopedic Specialists was called Alexandria Orthopedic Associates. In 2007, the name changed to Heartland Orthopedic Specialists, because it's not just about one county or one town. And the fact that we saw folks from 186 different zip codes a couple of years back when somebody added them all up is why we're more regional, if you will. And that's where we partner with our local physical therapy folks, whether it's here, whether it's the Big Stone group, whether it's the folks in the Wilmer area that are now Caris Health. Really, some of the stuff that needs to happen after a surgery is handier to have it closer to home. But we do have physical therapy within our group. We really take care of you from the tips of your fingers to your shoulder. We do a lot of hip and knee replacements. A couple of years ago, we did a little over 700 hip and knee replacements on an average month. The busiest months are about 70 in a month. In June of this year, with a little backlog from COVID-19, I think we did 70 last month, and in July we're supposed to do about 72, so it might be a record-breaking month for people needing and being able to have hip and knee replacement. We do have Dr. Stika is a foot and ankle specialist, so anything from, he doesn't do a lot of ingrown toenail kind of stuff, but if you, especially complex foot surgery, he does ankle replacements. He's the only guy outside the Twin Cities really that does ankle replacements, so provides that care. And then we do have a spine team. Dr. Andrews is a physical medicine and rehabilitation doctor, so a physiatrist, does a lot of injections, directs physical therapy, that kind of thing. And Dr. Lindley is a neurosurgeon who works with us, so does neck and back surgery. So if you have a neck or back problem, we can take care of that too. And they've been with us for fewer years, for a few years now, but they're a little bit more recent addition to our team. If we look at the front-on view of a shoulder, there's a bunch of medical words here. This is the collarbone or the clavicle. The ball and socket right now is covered up by muscles that live in the front and out on the side, and this kind of purplish thing represents the bursa, which is a lubricating surface around the shoulder joint that's kind of outside the joint but underneath the skin, if you will. And one of the things about the shoulder that's kind of unique is if we think about all the wonderful things we can do with our shoulder, we can scratch the back of our head sometimes, we can scratch up our back. There's great range of motion, but it's because the ball and socket's a pretty shallow socket, so it's a little bit more like a golf ball sitting on a golf tee. With that said, we rely a lot on the muscles around the socket. So this is a cutaway where the ball has been removed, and this white stuff in the middle is the cartilage of the socket, and all of this red stuff around the edge, those are the muscles of the rotator cuff. So the rotator cuff, and I see a lot of folks, there's a lot of people that know a lot about rotors, and some people that are in rotary. So we sometimes hear about the rotor cuff or the rotary cuff. We call it the rotator cuff, but really what it is a group of 4 muscles. And if you want trivia to impress your friends, you can tell them that there are 4 muscles in the rotator cuff. And the supraspinatus, infraspinatus, subscapularis, and teres minor, those are the names of the muscles. But think about all those things sort of converge around the ball and socket, and a tendon attaches that muscle to the bone. And those muscles, through the tendon attaching to the bone, is what allows us to sort of lift and rotate our arm and do stuff out in space, like getting glasses out of the cupboard, reaching, pushing, pulling, that kind of stuff. If you have pain when you lift your arm up, sometimes laying on our side can give us pain. Weakness is probably one of the hallmarks of rotator cuff disease or pain. So pain combined with weakness. So the grinding sensation when you move, that can be the case. Sudden onset versus sort of gradual over time. If someone has a fall and lands on it,
Those are kinds of things that sometimes make us more urgently aware of if it's a rapid onset or an acute tear, we call it. Those are more likely ones that may need to be treated with surgery and maybe more successfully treated with surgery than something that's gradually torn over a period of a lifetime. If you think about a rope that's gradually fraying, and then finally gives up, it may or may not be as successful. As an orthopedic surgeon, I frequently talk about something called shoulder impingement, this last word. But sometimes the patient will say, okay, doc, give it to me straight. I saw my family doctor and he said I had tendonitis. I saw my therapist and they said I had bursitis. Now you're telling me I've got this thing called shoulder impingement. Which one of you is right? Because my shoulder's the same. Hurts on the side. It's worse when I raise my arm up and I can't get the cupboard stuff out of the upper cupboard. Well, they're all the same thing. So tendonitis is inflammation of the tendon, how that muscle attaches to the bone. Bursitis is inflammation of that lubricating tissue that helps us not have stuff get stuck when we move it around. And impingement is a term invented by a guy named Dr. Neer in 1972, who talked about this combination of things and sort of wrapped it into one word that we call shoulder impingement. So impingement is kind of an orthopedic term. They're all talking about the same thing. So what do we do if we have shoulder impingement? If we're pain, some weakness, irritation of either the tendon, the bursa, all of the above, I think of it as an orthopedic buffet, not just because we're here going to have dinner, but at one end of the buffet is do nothing. At the other end of the buffet is do a big operation, and in between there's a whole bunch of stuff. At the conservative end of the buffet are modification of activity. If it hurts when we get the crock pot out of the top cupboard, maybe move the crock pot to the lower cupboard. Change what we do. Don't do as much overhead stuff. Resting it sometimes helps. Medications, Tylenol is something that's very safe. Right now, with COVID-19, there are some recommendations about avoiding anti-inflammatory medicines. If you think you have COVID-19, don't take ibuprofen apparently, but if you don't think you have it and ibuprofen helps your arthritis pain, if your ibuprofen helps your arthritis pain and not taking ibuprofen makes you miserable, then there's maybe some benefit to taking the ibuprofen for the arthritis pain. We think about physical therapy, so Craig and his folks, or whoever your therapists are, can help reduce stiffness. A stiff shoulder is a painful shoulder, so just doing a little therapy, even if it doesn't necessarily change, whether it's arthritis or a torn rotator cuff, there's a lot of stuff that can be done with great success. We sometimes do injections of cortisone or a steroid shot to calm inflammation. Most commonly that's done in the bursa, so that lubricating space between the cap of your shoulder and the rotator cuff. We can put those medicines in the ball and socket. So if you have arthritis, sort of like a knee with arthritis, we do cortisone shots there. We do them in the hip, we do them in the shoulder. And if there's no tear, there's about almost a 90% success rate doing non-surgical stuff for shoulder impingement or bursitis, which is pretty good. So if you can avoid doing surgery, nobody that comes to see me with a shoulder problem says, "Hi doc, I'm here to sign up for surgery." They say, "I'm here because my shoulder hurts and I want the pain to go away and I'd like to do it with as much of this end of the buffet as possible and avoid the surgery end of the buffet, and I'm on board with you." Say we can't get better without surgery. Say we're one of the 10% of people who doesn't get better with the rehab stuff. So range of motion, strengthening, stretchy rubber bands, that kind of thing. If we don't have to repair the rotator cuff, I call it the 6-week plan, which just means that after surgery, it's still a same-day surgery, you wear a sling, but only for comfort. So you don't have to be strapped to that thing forever. And everybody knows somebody who's had that black thing with the pillow that holds their arm there, and some people in the room have had that. But really minimal restrictions if I don't have to go fix something. The term that we sometimes use is a subacromial decompression, which is sort of another one term to talk about removing inflammation of the bursa, any bone spurs. The end of our collarbone, sometimes when I see people, I poke on the end of the collarbone and say, "Does that hurt?" And if people say, no, that doesn't hurt, then we leave it alone. Everybody in this room on an x-ray probably has some arthritis of the end of their collarbone, maybe with the exception of our videographer. If we've been on the planet for 30 years or more, we're going to have some arthritis on an x-ray, but if it doesn't hurt, leave it alone. If it does hurt, we can take a couple millimeters off the end of your collarbone as a pain relieving thing. Sometimes the bicep tendon is worn or partially torn, and sometimes we do something to that. If people rupture their bicep tendon on their own, I call that the John Elway plan, because those familiar with him, he ruptured his bicep tendon before he won the Super Bowl twice, throwing for the Denver Broncos as their quarterback. If you have somebody like me as a surgeon cut your bicep tendon, I call that the Brett Favre plan, because he had a surgeon cut his bicep tendon before he played for the Vikings. And whether you're a Brett Favre fan or not, you threw the football okay after that operation. So the bicep tendon can be a pain generator, and there are different ways to treat that. Some people detach it and reattach it, and that's a little more surgeon independent and specific to every person's shoulder problem. So if we look at tears of the rotator cuff, so this is where the tendon actually gets detached from the bone. There are partial thickness tears, so it's not completely detached. And those can actually be more painful than what we call a full thickness tear. Think of it as a rope that's fraying but not quite ruptured, that there's a lot of load that goes through the part that's frayed but not yet torn. So people will sometimes say, boy, I had an awful lot of pain, and then I had a snap or a pop in my shoulder, and my shoulder doesn't hurt near as bad, but I can't lift it up anymore. So that might suggest a partial tear that's become a full thickness tear. We sort of use 50% as a rule of thumb. So if on somebody's MRI, a rotator cuff is not torn all the way through, and less than 50% is torn, there's a lot more success in treating that without surgical repair. If more than half of it is torn, we tend to be more likely to repair it. And one way to think of it is that if it's less than 50% torn, for me to fix it, I might have to go and detach more than what is already torn in order to go fix it. So why not just leave it attached? Whereas if it's 90% torn and only 10% not torn, we can tear a little bit of it to go grab the whole thing and put it back where it came from. Again, a full thickness tear, it's completely torn from the bone, more likely to cause you weakness, maybe a little less pain, and that's kind of the difference between a full thickness tear and a partial thickness tear. So here's a little cartoon. These are courtesy of the Academy of Orthopedic Surgeons. It's on their website. This is a front-on view of a shoulder, and we're talking of the supraspinatus is the most common tendon to get torn. So if we focus on this area here and compare it to this area here where there's this little half-moon shaped area, that's effectively what a full thickness tear looks like. If we look from the side, so here's the arm bone here, and this is normal. So the muscle is here, you can see the stripes in the muscle. The muscle becomes tendon, which is more white, and this part is normal, whereas this part, the tendon is torn away from the bone. So that's what a torn rotator cuff looks like. And then the question is, will it heal on its own? The answer is no, but do I have to have surgery? And that's where it gets a little bit muddy, which is why we don't just jump in and say, you have a torn rotator cuff, let's go fix it. If we look at a group of people in their 80s, about 80% of people in our 80s will have some tearing of our rotator cuff and not necessarily know it. As we go to younger decades of life, that rate is less, but not zero. And if we look even at people who have a torn rotator cuff, in the recent study that was done, looked at a bunch of people who had an MRI-proven rotator cuff tear that was a full thickness tear, and then they treated everybody with physical therapy, and they followed them at 6 weeks, 3 months, out to 2 years. And in that study, and they let the patient decide, when they came back, they said, are you all better? Are you heading in the right direction? Or are you no better? And they found that only 1 in 4 people with a known MRI-proven full-thickness rotator cuff tear decided to have surgery at 2 years. So that tells us a lot about, do we need to just jump in and have surgery? Just because it won't heal, does that mean that you're doomed to surgery? You're not. They did find that the vast majority of people that decided to have surgery knew that within the first about 12 weeks. So if they saw them at time 0 and 6 weeks and 12 weeks, the people that decided that they weren't doing okay with not doing surgery knew it within about the first 12 weeks. And that's when we and our physical therapy colleagues say, well, how much therapy is enough? How long is it going to take us to know? We sort of use 12 weeks or 3 months as a guideline to say, well, if we see you 3 days after you start therapy, you haven't had a chance to get better yet. But if we do therapy and maybe see you at 6 weeks and see you again at 12 weeks, we get a better idea of are you headed in the right direction. So it's something where to just jump right in and say, should we go fix it? That's not necessarily something we have to do. Rotator cuff repair surgery puts you on what I call the 6-month plan, and that's where everybody kind of shakes their head and gets a little bit of a scowl on their face, because no matter how we add up 6 months, that's half a year. And even though I slow you down for half a year, I tell you that you're going to continue to get better for the first full year after surgery. And there's someone who lives in this community who I saw at Tom's Market about 18 months after surgery or 2 years, who said, remember how you told me it was going to be a year before I was all, recovered? I continue to get better for a year and a half or 2 years, but I'm doing great right now, kind of thing. So it's a long recovery, but it's something that definitely you're slowed down for about 6 months. We still remove the bone spurs, we reattach the tendon to the bone. You're in a sling for a month, so you're not in a sling for half a year. But you're for sure in a sling for 4 weeks, sometimes 6 weeks, but more often 4. A couple times a day you come out to let your elbow bend and straighten, kind of thing. And then you start therapy at about 4 weeks. This is a picture of a torn rotator cuff. So we're looking from the side of the shoulder, and this is a pretty worn out rotator cuff. So here's the ball, here's the socket. This is the tendon. This part used to be attached over here. And this looks like there's a bunch of macrame that we did, which we did through the fiber optic scope, but this is before, and this is after, so the tendon is reattached to the bone. You can almost think of it as if the comforter on your bed is pulled down from the mattress a little bit. What we do with surgery is through the fiber optic scope, so multiple little incisions about 1/4 inch, and the instruments are about the size of a ballpoint pen. We kind of pull the comforter back up to the top of the mattress and then staple it down. The slow part of the healing is getting the tendon to stick down to the bone. And that's why it's the 6-month plan, if you will. If we look at, so we talked about not everybody that has a rotator cuff tear needs surgery. Which ones do better with surgery or which ones do worse? Things that do better, smaller tears do better. If the muscle attached to the bone or muscle attached to the tear is healthy, that's better. So one of the ways, or one of the analogies that I use is if we look at someone's muscle on their MRI, and it's about half atrophied or shrunken down, the muscle gets replaced by kind of fatty tissue. That fatty tissue isn't muscle, so it's sort of like having an 8-cylinder engine, and if it's half atrophied, your V8 became a 4-cylinder engine, and it won't ever be a V8 again. But there's still some horsepower in there. So if you don't have atrophy of the muscle, that's better. If you have a lot of atrophy, then it's less successful. A traumatic tear, so somebody that had a normally functioning shoulder and said, I fell down 3 weeks ago and now I can't lift my arm up, that tends to be a better prognosis than someone who says, it's just gradually been wearing over the last 5 years. And if people have good bone quality, that helps. So being active is helpful. We need to have solid stuff to reattach it to, whereas folks that have poor bone quality, a lot of atrophy of the muscle, so say your 8-cylinder engine is completely replaced by fatty tissue, and you've got a 0-cylinder engine, we can reattach the tendon to the bone, but it doesn't have a motor attached to it anymore. So those are folks that have very high risk of failure with rotator cuff repair surgery, and the larger the tear, the less well they tend to do. So what if we can't fix it? So sometimes we'll get into a shoulder and say, okay, we want to fix this thing, and then we try putting stitches in, and it's like putting stitches in wet Kleenex. Doesn't hold very well. Up until about 2014, we didn't have an answer to that, really, on planet Earth. And what we would do is go clean stuff out and say, I'm sorry, I couldn't repair your rotator cuff. People tended to get pretty good pain relief from that clean it out kind of procedure. But at that point, there wasn't more to do to it. And in 2014 is when the publications came out. But a Professor Mahata from Japan invented a procedure. He first started talking about it in about 2008. They first did a series of patients in 2012 and then published it in 2013, where they did a procedure called the superior capsule reconstruction. It's a little easier just to call it the patch. And they described 25 people that they treated with this patch procedure that, again, was an operation for a rotator cuff tear that wasn't able to be repaired. So people had pain, inability to raise their arm up, interfered with their day-to-day activities. And in Japan, where he was practicing, there's a shoulder replacement operation that wasn't available to him, that we'll talk about at the end of the talk, called a reverse shoulder replacement. So he didn't have that tool in his toolbox, so he invented this other thing, this patch procedure, and looked at people that had tears that they couldn't fix, they didn't have arthritis, and they had didn't have a stiff shoulder, they had pretty good passive range of motion, and they found about 80% success of that procedure. It's still the half-a-year plan. I'm the guy in our group that does that operation because it's not a very commonly needed procedure, so we've sort of funneled them to me because I have an interest in rotator cuff problems. So there's probably 30 people or so in the last about 3 years that I've been doing that operation. And this is a cartoon, so the company is called Arthrex that provides the anchoring devices. And you guys are getting ready to eat, but at the end of the talk, I brought these are actual implants that you can come and see what it is that we put in people's shoulders. And there's a little foam bone that's like a pretend rotator cuff tear. So if you want to come and look at underwater macrame with chopsticks in person without any gore, you're welcome to come up and check that out at the end of the talk. But this is a right shoulder, so we're kind of looking down at it. This is one of the rotator cuff muscles in the front that's okay. Sorry, I went back, please. This white thing here is the patch, if you will. And we can see here it's attached on the socket side of the shoulder. There are a couple stitches here to reattach it to the rotator cuff tissue that was healthy. And then this crisscrossing construct is how we reattach it to the bone out at the side of the shoulder. So this patch, think of it as sort of an upside down trampoline. If the ball is slid up on the socket and we can put this thing in to push the ball down on the socket, which then allows people to raise their arm up, that's how it works. This is made out of skin, so someone donated their body to science so we can use it for your shoulder, but it's all processed tissue that we get through this company called Arthrex. And these are some surgical pictures of one of my patients who said I could share her pictures with the world. So this is looking from the side of the shoulder. Here's the ball, here's the socket. All this kind of white stuff is the rotator cuff that's torn. And we tried putting stitches in it, and it was like wet Kleenex, so this was not a repairable tear. So a large tear that we couldn't fix, and the ball and socket's pretty smooth. We then cleaned out this stuff. You can see from this picture to this picture, that stuff's gone away. There's some rotator cuff tissue there, and some in the front. Here again is the ball and the socket. We put some stitches on the socket side, and here you can see some of these little sutures that are coming out from the edge of the ball. So here we've got everything prepared for the patch. This is an actual picture of the patch. Went the wrong way, sorry, bear with me. So as we look at the patch here, we haven't put it in the shoulder yet, but we passed stitches through the patch here, here, and here, and here, and here. And then we get it all ready, and there's our sutures through the shoulder, and then this is before and this is after. So if we go back to this really being before, and that's the same picture when we put the patch in. So that procedure, again, it's only been around for about 6 years on planet Earth. In the United States, it's been very popularized over the last probably 3-4 years. So it was about a year that it had been going on in the United States. before I added it to what I do, and it's something that's another tool in our toolbox that has been very successful. It's about 80% successful as far as people not having to have another operation on their shoulder. Nobody knows the 10-year durability of it because it's not been on the planet for 10 years, but it's something where we've got a tool in our toolbox that we didn't previously have, so that's a pretty exciting thing. It's still a same-day surgery, so really for folks that have big rotator cuff tears that I don't know if I can fix them or not, because I can't tell from an MRI whether it's going to be repairable or not, we will sometimes talk about either we're going to fix your rotator cuff or we're going to do the patch procedure, and we're ready for both, and they're both done in the same setting. So we kind of go in with the kitchen sink. As we get kind of toward wrapping up here, I want to talk a little bit about arthritis. So there are a few different kinds of arthritis. Osteoarthritis is wear and tear arthritis. That's the most common kind of arthritis that we see. Other kinds of arthritis, rheumatoid arthritis is an example of an inflammatory arthritis that's really an autoimmune disease where the body kind of attacks itself, if you will. And cuff tear arthropathy is kind of a big medical mumbo-jumbo term that really means arthritis caused by a torn rotator cuff. So if you think about the rotator cuff, its job is to push the ball and center it down in the socket of our shoulder joint. So if we've got a ball and a socket that fit together nicely, if the ball slides up on the socket, it sort of edge loads that ball and socket, which can result in arthritis of the shoulder because of the torn rotator cuff. So how do we figure out what you have? This is my new recently retired colleague, Dr. Brand. That, I think, is Angie right there as our expert model. Good job, Angie. So we talked to you about it. Have you had an injury? So is this a new tear? Is it an old tear? Have you had previous surgery? That kind of thing. We'll examine the joint to see, do you have good range of motion? Is your joint stiff? Do you have weakness or not? Imaging, x-rays are important. An MRI shows us the muscle or the tendon. An x-ray doesn't show that directly, but it shows the bones, and if the ball and socket are out of alignment, that can make us suspicious of a torn rotator cuff. But sometimes we need other imaging like an MRI. People with pacemakers frequently can't have an MRI, so there are some things that can be done with like a CAT scan to look at that in different ways. Ultrasound can be used to look at the rotator cuff. So there are a few different ways to look at that. But this is an x-ray of an arthritic shoulder. So it's a right shoulder. This is the cartoon version. So here's the ball, here's the socket, here's a bone spur sticking down. And on the x-ray, here's a bone spur. The space between the ball and the socket is narrowed. In this ball and socket, the ball isn't really slid up on the socket. So in this x-ray, I wouldn't be suspicious of the rotator cuff being torn. I would look at this and say, you know, it looks like your rotator cuff is probably okay, but either you had an injury or you got genetic predisposition to arthritis. We live in a place where, for whatever reason, people in the part of the country that we live in, arthritis runs in some of our families, and that just kind of is what it is. So this is what an arthritic shoulder looks like. And if we're going to replace an arthritic shoulder, there are really 3 different ways to do it. We can do a partial replacement where we just replace the ball, and there are 2 kinds of that. So we'll show you a picture of resurfacing. Hemiarthroplasty just means half of a replacement. There's the total shoulder, which is the ball and socket, and that's a traditional total shoulder replacement. And then this reverse total shoulder that's specific to people with a torn rotator cuff. So a shoulder resurfacing is literally like capping a tooth. So the component is metal. There's a little cruciform or cross-shaped stem that grows into your bone. And this is a left shoulder where this partial replacement has been done that doesn't replace the socket side of the shoulder. But when I see folks and tell them if I replace your shoulder and we do a total shoulder, that the most lifting I want you to do ever is that 40-pound bag of water softener salt that goes in your brine tank. And that's kind of a permanent thing. And some people say, that's not compatible with what I want to do if people are farming or just want to do stuff. This is an option of this resurfacing because the weak link in the chain of a shoulder replacement is the socket replacement. This operation doesn't replace the socket, it just replaces the ball. So once you recover from the surgical procedure, so a couple months down the road, you can do whatever you want to do with that. If you're a bodybuilder at Venice Beach in California, the people that take care of bodybuilders in California, they'll show the picture of Muscle Man after his or her partial shoulder replacement because they want to go back and lift really heavy stuff. Where we live, it's somebody that wants to go farm and throw hay bales and that kind of thing typically. If we look at a total shoulder replacement versus a reverse total shoulder replacement, so on the left side is the total shoulder, on the right side is the reverse, and what's reversed is if you look here, here's the socket and the ball, kind of like a normal shoulder. Over on the right-hand side, here the ball has been put on the socket side, and the socket is on the ball side, if you will. That's why the name reverse shoulder replacement. What it does is sort of changes the mechanics of how the shoulder works so that we don't have to use our rotator cuff to raise our arm up. We use a different muscle next door called the deltoid muscle. And this is something that's only been in the United States since 2006. So they were started being done in the United States in 2006. So by 2016, there was some 10-year follow-up, and it was just about a year ago that the first 10-year follow-up of reverse total shoulder replacement in the United States was published, because our concern as surgeons was, how is this thing going to hold up? This is a pretty end-of-the-road operation, so if it gets loose or it dislocates or is unstable, there's not a great plan B, if you will. And the good thing is that reverse shoulder replacements really are holding up very well at 10 years. There are some risks with them, and they tend to be best utilized in people who are fairly low demand, meaning we're not out running the chainsaw and splitting wood and that kind of thing, doing carpentry. But for someone who can't raise their arm up to fix their glasses or comb their hair or feed themselves, if we can't get our hand to our mouth, that's a big deal. If we can now take care of our own day-to-day activities and sometimes remain independent in our own home, it can be a real life-changing thing for the better, but it's really an end-of-the-road operation, the reverse total shoulder. This is an x-ray of a traditional shoulder replacement. So here's the ball. The socket is invisible on x-ray because it's plastic, so that it looks, this black space is where the plastic is. There's a couple little white things that are part of the socket. And the comparison, here's a reverse total shoulder replacement that shows the ball on what was the socket side. The socket is plastic and is attached to what was the ball side, and there's a component that goes down into the bone there. With any surgery, there are risks and complications. Risk of infection, we give people antibiotics at the time of surgery. Rotator cuff repair, blood clots are not such a risk. Shoulder replacement, there's some risk, and some people are on blood thinners after surgery. Not heavy blood thinners typically, but maybe an aspirin. They can get loose, they can wear out, so anything that we do is something that has risk of mechanically failing over time. But again, even that reverse total shoulder replacement in the United States that's now had a 10-year track record is performing pretty well. That patch procedure I mentioned doesn't have a 10-year track record on planet Earth because the guy in Osaka, Japan only invented it in about 2012, so we got to kind of stand by on that. But that patch procedure could be converted to one of these other shoulder replacement operations. So with that procedure, we haven't burned any bridges. As we always think about, oh, what if this somehow fails, gets loose, that kind of thing. So when do you have shoulder surgery for any of these things? Rotator cuff tears, shoulder impingement, arthritis. Really, if things other than surgery, the conservative end of the buffet isn't effective, that's time to have surgery or consider it. Quality of life is a huge thing. We don't do a lot of life-saving stuff in orthopedics, but we do quality of life-saving kinds of things, whether it's hip or knee or shoulder replacement. Having a conversation with your surgeon to say, is this going to make me better or is it just going to make me different, is important to consider. And really, this is about you. It's not about me. I'm here to give you options. And if you feel like, my quality of life is so severely affected, and we talked about what are the likelihood of success and the likelihood of not being successful, and then feeling what feels right in your head and your heart is kind of the way to go about it. So in closing, we need to make sure that we've got the proper diagnosis. So if I do a great shoulder operation on you for neck problems, that doesn't help you. That makes you different. Many things in the shoulder can be controlled without surgery, and there are a lot of non-operative management options available. Some of them include physical therapy. In fact, most of them do. If those things don't work, then we migrate down the orthopedic buffet to things that are a little more invasive, a little more recovery time, and ultimately, if not doing surgery is not effective, frequently there is a surgical option, and that's where people like me come in to give you an idea of, is it successful, is it going to be less successful, what are the risks?